Thanks. Hi, everyone. I'll go ahead and get started. This is our Ivy Lab in Recovery meeting for September 2025. I am the new Ivy Lab coordinator, Michelle. So excited to see everyone here today. So here's some grant updates. I'll go over the things highlighted in yellow. One of our other grants with NIDA and NIH is the mechanistic study of the role of orexin system and sleep disturbance within a buprenorphine opioid use disorder treatment sample. Another grant with the Jeffress Trust Awards program. The title is Advancing Health Equity for Birthing People with Substance Use Disorders, with a capacity of building a community partnership team for intervention, development, and implementation research. Another grant with NIDA and NIH is the Health Equity Informed Delivery of Cognitive Behavioral Therapy for Insomnia, adapted for individuals with opioid use disorder. And another NIDA and NIH grant is the phase 3 double-blind randomized controlled trial of suvorexant versus placebo to treat insomnia in persons with opioid use disorder. Moving to our next slide, here are some published manuscripts. The first one at the top is our most recent one, and it's on inpatient buprenorphine initiation for treatment of opioid use disorder in pregnancy and postpartum. And then our other three, the titles are Characterization of Inflammatory and Neurofunctional Markers in the Context of Early Life Stress among a Clinical Sample of People Maintained on Buprenorphine for Opioid Use Disorder. One of the other ones is the psychosocial correlation of insomnia symptoms among women and men receiving buprenorphine treatment for opioid use disorder. And our last published manuscript is the opioid use disorder cascade of care among people who experience perinatal incarceration, a qualitative study. So super excited about these published manuscripts. Next are some of our manuscripts in review. They're currently in review with either ACOG, the American College of Obstetricians and Gynecologists. It's a Friday. And then the other one is in review with alcohol with clinical and experimental research. And those titles include resource utilization among racial subgroups in an integrated obstetric addiction clinic. And then the next one is the sex-based differences in neurofunctional domains among adults with severe alcohol use disorder. So super excited about those. We'll probably get some updates very soon. Here is some social media profiles. Please make sure that you follow and engage with us. We are revamping a lot of our social media platforms, so you'll see a lot of things coming from us soon. But here is our X profile. Here is our YouTube channel, which our Ivy Lab meetings will be added. Also, our WAG meetings that we have too, they will also be added onto the YouTube channel. Here is our LinkedIn and our Instagram and our lab leads. So I was just talking about the social media platforms that is managed by Arjun through media. Our next lead is Dr. Madison Marcus, who is under regulatory data. We also have Amber, who's another one of the coordinators. I am kind of transitioning with her role. And then we have James Bacon, who's under community engagement. We also have another Michelle, who is the interventionist. And we have Dr. Austin Jones, which is the regulatory data. I have not added my picture. I'm still actually waiting for one of my professional pictures to come back. So you'll see my face up there soon. And another person that's unpictured is Nicole Boss. For Project SORT, next I'm going to go through a couple of our projects that we're currently doing. We still have Project SORT, which is investigating the relationship between sleep and opioid use disorder and recovery. And it includes some of the lab members still working on this study. Another study is the registry one, It's tracking clinical outcomes of pregnant and postpartum patients who seek addiction treatment with our OB Motivate clinic. And it includes some of the lab members working on this study. And then we have the CBT-I study, which is adapting cognitive behavioral therapy for insomnia, specifically for people with opioid use disorder. And you can also see the lab members working on this study. And then we have Lemborexant 2.0, which is a medication treatment study testing the effects of Lemborexant on insomnia and impulsivity among people with opioid use disorder. And just to reiterate, we're going through active recruitment with this study. We also have Suvorexant, which is a phase 3 double-blind randomized controlled trial of Suvorexant versus placebo on insomnia among people with opioid use disorder. And we are still within the planning stage of this study. Project Castle is in its pre-testing phase, but it's about the development of computerized intervention that educates pre-medical professionals on substance use disorder stigma. And some of our educational studies, we have a clinical research curriculum study that is ongoing, and those students are preparing to attend the VASAM conference. They've already submitted their abstracts last week. We have the First Steps project, which was previously the Jeffress project, which you could also see in the beginning of our presentation. It's one of our main funders. And this is addressing maternal morbidity and mortality by adapting a patient navigation model for birthing people with substance use disorder. And moving on to our lab meeting announcement, we'll have another lab meeting in October. And during that meeting, we will talk a little bit further about those VASAM abstracts that were submitted. But we hope to see you all there. I will send out that information pretty soon. Thank you again for your time. And if you have any updates, please feel free to email me at michelle.colbert@vcuhealth.org. I also come up on colbertml@vcu.edu.
Thanks, Michelle.
No problem.
We have a lot going on in the lab, so it's nice to be able to showcase everything across the spectrum. So, yes. Great. So we're going to transition into our presentation today. So Leah, we're going to hand things over to you. And Leah, just before you start, just make sure you introduce yourself, who you are, where you're at, and all the things. And also the caveat that you're looking for feedback, like we talked about the other day.
Yeah. Before I share my screen, I will first introduce myself. Well, for you all who don't know me, my name is Leah Vines. I'll be joining the lab next year over the course of 4 years for my PhD portion of my training. I'm in the MSTP program. So if you all don't know what that is, it's a NIH-funded MD PhD program. So my first 2 years, I'm in med school and I'm almost done almost-ish done my second year. And then I'll be going into grad school. And I just rotated in the lab this past summer and I worked on the CBT-I study. And as part of my MD PhD requirements, I have to give a presentation to the program and the program director, just kind of giving a summary of what I did this summer. And the background of the people, a lot of them are basic scientists. I would say like 90+% of them are all basic sciences, so they don't have a lot of background in opioid use disorder besides of like probably what's taught in med school or maybe some clinical rotations they've had. And now I will go ahead and share my screen. And also at the end of this, please welcome feedback. This is kind of like it's all put together. This would be like my first round of practice. So bear with me. Okay, let's see. Let's see. Can you all see my presentation?
Yes.
Okay. Can you see me advance forward?
Yes, we can.
Okay. All right, perfect. Well, hello, everybody. Today I will be talking about just some updates about the CBT-IO protocol with you all. So first, I want to open that I decided to have my PhD be completed in the recovery lab called the Ivy Lab, led by Dr. Kaylin Martin. And first, I just want to emphasize the range of opioid research and exactly where this lab fits into that space. So first, I just want to open up whenever I refer to this acronym MOUD, you'll see it throughout my whole talk. It's referring to patients who take medications for opioid use disorder, and I'll go into detail a little bit later about that. So there is a pretty wide spectrum that people use to investigate opioid treatments, all the way from like harm reduction, looking at like behavioral and biological phenotypes of opioid use disorder, so people that are in the more active use stage. And there's also quite a few studies looking in the more detox phase when people are transitioning out of using, and then where the lab fits in, and also where my previous research I did at NIH is focused on people in long-term recovery, because we know these treatments aren't working, and our goal is to make sure that people stay in the treatments. So first, I just wanted to give an update. This is released by the CDC pretty recently. It's the same graph that they show every year. And as you can see, over the years, the major driver in the opioid crisis and increasing overdose deaths have been the type of opioid that has been available to people. And you can see a big wave that has happened around like 2019. But one update that looks really promising, it's not a dramatic decrease, but there has been about a 2% decrease in overdose deaths. And now for treatments for opioid use disorder, there are two types of treatments. This is just a table kind of simplifying for you all the different types. So there are two, and both of them are opioid agonists. And one is buprenorphine, which is a partial agonist, and the other one's methadone, which is a full agonist. So what that means for the partial agonist, you're going to see less feeling of the effects, or like less feeling of euphoria when people take it. And also there's less likely for dependence on buprenorphine versus Suboxone. It's a full agonist, and also there's not much protection for overdoses. And it is typically, but this is what the table says is more effective for dependence. I'm not really sure on how much evidence there is to back up on that. So yeah. And as I said before, we know these medications are working. And this is just a chart summarizing how there's more and more physicians prescribing these medications because we know they work. So we know that they reduce morbidity and mortality. So we see greater reductions in overdoses and less acute serious complications like cardiovascular complications related to substance use. And also we have less transmission of infectious diseases since less people are using. And also, there's just overall improved quality of life. People are able to return back to their jobs and just return back to their normal life now that they're getting treatment. And something I really want to emphasize is the first study I have bullet pointed. It's a very interesting study that they did. They compared lots of different treatment programs. And what they found is that people that are on the medication treatment versus like people who are on detox who don't use any medications, it seems like people in the medication seem to be doing better compared to people who are not taking them. And since we know these treatments are working, it's very important for us to keep people in these treatments. And something that has been consistently investigated very recently, actually within the past 5 years, is insomnia in people with opioid use disorder. So we see it in people in acute recovery. So this study looked at people that were previously using, and then they entered into a program and started being initiated on medication, specifically buprenorphine. And it's interesting. So when the patients first entered, they had them fill out a questionnaire to look at their insomnia severity. And they also filled it out towards the after end of their treatment. And then they saw that there was greater odds of people returning back to use. And we also see this in long-term recovery, where people just have overall greater, people with insomnia with opioid use disorder have greater overall pain and stress and psychological distress compared to people with opioid use disorder and no insomnia. And also a study that was done with the Ivy Lab and also a fellow MSTP student, Gus White, and he did a study looking at the neural correlates involved in insomnia and OUD. And another thing was also some qualitative questionnaires they did. And something that they found is that people with insomnia were more likely to feel that their sleep was being interfered with their treatment. And a big branch of why the CBT-IO study was developed is a qualitative study that was done in the lab that looked at patients' preferences for insomnia and sleep treatments. And what they found is that patients did prefer behavioral and medical interventions for sleep to be integrated into their substance use treatment. And also, they would like therapies to be flexible for their schedules. And actually, some participants preferred some telehealth therapy, and while some participants preferred to be in person to have them feel more accountable. Before I get into the details of the study, I first just want to explain what CBT-I is. So it is the gold standard treatment for people with long-term insomnia. And what it is that you have sessions one-on-one with a psychologist or a therapist or mental health professional, and you go through making an individualized treatment plan to help with your sleep behaviors and get better sleep. So one major component is in the name. There is a cognitive component, just assessing people's attitudes about their sleep. And also they go over relaxation techniques like different meditations. And some other components is sleep education. So this is talking about, like, for example, avoiding caffeine or alcohol 2 hours before bed, and make sure to do relaxing activities before bed. And also there's sleep restrictions. So a goal in insomnia treatment is limiting the time people spend in bed without sleeping. So this is something emphasized in the treatment. And also stimulus control, which is keeping activities limited to the bed for sleeping and sexual activities only. Okay, so the aims of this study is a multi-aim study. So first, the goal of the study is to adapt CBT-I to opioid use disorder. And what that includes is adopting questions that are related to taking their buprenorphine medications and the timing around sleep. And also there is an application of a social determinant model approach, which pretty much is that what people do is a shared decision-making with the patient, and based on their preferences, that is how the treatment would be delivered. So some people do telehealth appointments while some people get their intervention in person. And also there is some feedback from community members to make sure people in the community feel like this intervention is coinciding with their experiences. And there is a pilot testing phase. So before we can get to comparing this intervention to anything, we first have to see if the quality of the data, how the quality of the data is. And this involves quality checking the data. So this is something that I did over the summer, which is pretty much visualizing the data, keeping track of how much missing data there is or abnormal variables that do not make sense. And also another goal of during this phase is just comparing the objective and subjective measures of sleep. And I will get into that later. And finally, we really want to see whether this intervention works. So participants in this latter part of the study will be randomized to either the CBT-IO treatment or treatment as usual, where patients would get education on sleep hygiene. And we plan to compare their OUD-related outcomes. So that is going to be related to whether they continue taking their buprenorphine medications. And we also have urine drug screen. And then we also ask and we also ask the patients themselves about their use. And these are yes or no questions. And we also are comparing their sleep outcomes as well. And the phase of the study we're at is in the pilot testing phase. And before I go any further, I just really want to emphasize the overall goal of this study is to see how cognitive behavioral therapy, CBT-IO, helps people with their severity of insomnia from baseline compared to the end of the intervention. And we hypothesize that there will, in fact, be a reduction and that these will be stable across time. So I want you all to get an outline of a participant's experience in going through this study. So first, participants are recruited from the Motivate Clinic. Some of you may have heard of this and done your rotations there. If not, this is a place where people go to get into recovery. And this is like where they're able to get their buprenorphine medications and be maintained on those. And this is where a lot of participants come from. And a really cool thing about this study is that We know that there's a need to implement this intervention at this clinic because of previous studies done by this lab showing that there's a high prevalence of insomnia in this very specific patient population. So after they go through their first visit, then they come in screening for eligibility. And the nice thing about this study is this study does not have very extensive inclusion and exclusion criteria compared to others I have worked on. So for over on the left side, you'll see the inclusion criteria where pretty much all it is adults 18 and older who are in more long-term recovery. So that's for at least 6 weeks and have a diagnosis of opioid use disorder and who have clinically significant insomnia, which is declared by a questionnaire I'll go into a little further, which is used to determine the degree of insomnia. And the main exclusion criteria are related to severe sleep disorder, so like obstructive sleep apnea, having narcolepsy, or having any severe psychiatric disorder that is screened through the DSM-5, and anybody who is pregnant or within 6 weeks of being pregnant. Okay, so now returning back to after we establish inclusion and exclusion criteria, and let's just assume in this scenario the participant is able to proceed through the study. They complete a baseline visit and they complete the intervention. So that is the CBT-I intervention where the participants have 4 one-on-one sessions with the psychologist and they're all 1 week apart. And then finally, participants do a 3-month visit. And that's the part of the hypothesis where I was talking about these changes will be stable over time, because we want only not to make sure like, okay, is the intervention working in real time, but we want to make sure that it can create a sustainable change for the patients. And during from the baseline and onward, participants fill out a sleep diary, which is something that's collected through REDCap, which is pretty much participants get a link on their phone every day, and they fill out questions on their phone. And also participants wear a watch that tracks their activity every day. And this is the more objective measure of sleep, and it's called an actigraphy watch. I would like to explain it kind of like an Apple Watch, where it tracks your activity and also tracks your heart rate and your circadian rhythm. And at each study visit, when the participant comes in, they fill out an insomnia severity score, and also they're answering questions about their OUD outcomes, and they also get a urine drug screen when they come in as well. So getting to the insomnia severity index, this index is screening for symptoms of insomnia and also screening how people think their insomnia is bothering them. And also we have the REDCap and actigraphy data, and this is a table summarizing the variables that we're getting from this. So you can see here where it says under REDCap, this is an example of the questions that the participant sees on their end. So, and it's just simply a text box and they type in how many minutes. So for sleep latency, this is measuring how long did it take you to fall asleep. And awake after sleep onset, this is asking the participant that if they woke up in the middle of the night, how long did those awakenings last? And then something that's automatically calculated by REDCap is the total sleep time and sleep efficiency. And all of these measures are available on the actigraphy data, but that is something that our biostatistician does, and she applies an algorithm to extract these variables. Okay. So this is some results from the first participant to complete the study. So you can see here, I did not include all of those variables that were available. It is because that unfortunately, well, this is clinical research. We did have quite a bit of missing data, but the good news is we figured out a lot of it was due to some issues internally in the REDCap system. And something I can imagine you guys are looking here, this may look a little weird that somebody's sleep efficiency is something that's over 100%, which is not a realistic value, but this is because that sometimes participants misremember some things or just enter things incorrectly, so the system calculates it based on how they enter it. But in despite of all these caveats, you can see here that this data has not been analyzed. It's just a visualization, but you can see here starting from baseline, you can see a very wide variation in both of the measures for sleep efficiency and total sleep time. And then you can see a huge jump once the intervention starts. And it seems like it still continues as the intervention proceeds, but we cannot have any conclusions, but this is a good sign that the data we're collecting is quality data. And this is showing the actigraphy data. So this is the baseline data. So to orient you all to what you're looking at, the peaks that you see in the graph is somebody's daytime activity and the drops is somebody's sleep time. So you can see here, there's pretty narrow windows for this participant's sleep. But you can see after the intervention, their sleep times become a lot wider and longer. This is just based on visualization, so it's hard to really tell if this is concrete. And I also did want to emphasize that you cannot see the variables I talked about earlier because those are still being processed by our biostatistician. And I just want to give everybody an update of where we are now in recruitment. And this is based on participants who completed the study. So we have 6 people complete baseline data. So that's really good in terms of our pre-testing and our publication that we're planning to doing, which I will talk about. And there's been 4 people to complete the intervention and do 3-month follow-up. And unfortunately, we did have 2 people lost to follow-up, but that is very, very, very good for a clinical research study to only have 2 people lost to follow-up so far. And these are the next steps in progress. So currently we are creating limitations for numerical values that the participants can enter. And the ones that do exist that don't necessarily make sense in terms of like negative values and high percentages over 100, we're declaring those as missing. And also we're troubleshooting some variables that were not being automatically collected in REDCap. And then also the actigraphy measures I talked about are still being processed. And there is a publication that is going to be in preparation soon comparing the objective and subjective measures of sleep because this is part of the quality assurance process. We want to make sure that these measures are measuring the same thing, even though they're collected in different ways. So we hypothesize there will not be any statistically significant difference. And this is just a sample table showing what this is going to look like. And that is it. Oh, I need to make a thank you slide, but that's it.
Yay, great job, Leah.
Thanks.
I love it. It's great to see, we worked so hard on this project for so long, and it's nice to see it when you're able to distill it so well down into a succinct presentation. We're like, oh yeah, we did do that.
Yeah, it was actually like I knew
Yeah.
it was really cool when I was doing it, but like making the presentation made me feel very excited about the project.
Yeah. It's nice to be refreshed, especially on like a Friday at 3:30 p.m.
Yeah.
Um, so I'm gonna I've already talked to Leah already and given her feedback. So I'm gonna open it up if people have questions, clarifications, or any other feedback given what she said at the beginning that this was practice for her presentation in front of her. Do you say program in front of her program?
Yeah,
Right?
my program. Yeah.
Next month.
Hi, Leah. I had a couple questions.
Mhm.
You did great. One of the things I know that you mentioned that you didn't have all like the data, that you were waiting for your statistician to come back. But I was curious because there seemed to be a couple, I guess, correlations with the graph that you showed as far as when the patients were the changes in like their sleep. Can you go back to that? I was just curious.
Yeah. Let me
I
see.
couldn't tell if there was like some correlations with the timing.
Is
Like,
it this
yes,
slide you're talking
yes.
about?
Does it tell you the time? Is that kind of what you were basing some stuff off of, that you're waiting for the statistician to come back?
Yes. So what we're waiting on is like, so this is kind of like the raw data, and the statistician applies an algorithm that allows us to take out like the sleep efficiency and sleep latency. So it's
Oh,
like more waiting for like those specific measures so we can actually do like a side by side of like, this is what the sleep diary looks like. This is what the actigraphy data looks like. And hopefully they're going in the same direction, but it's too hard to tell right now.
okay. I was just curious. I kind of personally focused on a little bit on the timing to kind of match up with like how other patients were looking, and maybe that was something that you could think about. And I know on one of your other slides, you were saying something about community stakeholders
Yes.
when some of the patients kind of work with them.
Oh, let me go back to that slide. Oh, I think it's here. Yeah. Wait, no, it's not this one. Oh, it's this one.
Yeah. I personally, I would add like who are the community stakeholders here. I think that that would be kind of
Okay.
helpful.
And I
Um,
also need to know that as well.
yeah,
Because I read the grant, and that's where I got
yeah,
a lot of this information from.
yeah. I understand. I think that's just such a
Yeah,
catch-all
no, that's
term.
actually really good. And also, and did do you all does anybody on the call know like off the top or like a good description for who I described these like experts are?
Yeah, actually, other Michelle, has this paper already drafted. So who has that? I know she's now postpartum. I don't know if I
I
have
can
them.
send,
Do you have it, Madison?
I can probably find it. It's probably in the drive somewhere, and I can send it to you, Leah, because that's the paper for like the whole development of CBT-IO, which I think would be really
Okay.
good background. And it includes
Yes.
like we sent it to an expert panel of people who have expertise in like sleep medicine and addiction clinic and lived experience with addiction to get all of their wonderful feedback on how we can make CBT-I the best for people with opioid use disorder.
Thank you. That is very helpful. And I'm also very excited to read that paper.
And then I had a comment just to go off of what Michelle was giving you feedback, Leah, on
Mhm.
your slide of the data, of the actigraphy data.
Yeah.
I think in addition to what Michelle said, I think taking since this is like your thing that you did, that you really focus,
Yeah.
I think taking a moment to orient people to the X and Y axis, what do the
Yeah.
just
Okay.
take a couple minutes to really break down this is what a red line means, and this is what the x-axis is what the right, and then you have your blue boxes. So just take a moment to really,
Okay.
especially with this audience, they're going to want to know everything in that graph.
Yeah. Okay. Okay. I know Madison sent me like the follow-up that has like everything labeled that I might just like walk them through. I think it's like a QC screenshot or of one of the sleep data points. So maybe I could add that and just kind of like walk them through it.
Yeah, that's with an update that Shan Shan just put out to her circa CP algorithm. So
Oh,
yeah, I can run these again with like the new version and send you screenshots of that to give you that like a little bit more detail.
that would be
And then
great.
and along with what Dr. Martin was saying, I would also make these graphs a lot bigger.
Bigger. I think I
Um,
just need to make them on two separate slides because I've tried putting them on the same slide so people can like see the back and forth, but I can't make them like bigger because they're so long.
yeah, I think having the comparison is good though because like visually, you can see that, like looking at the
Yeah.
blue lines, so the blue lines indicating like sleep periods when they're kind of down at the bottom, and then wake periods when there are high levels of activity.
Mhm.
You can see that during the intervention, those sleep periods are starting to get longer and more
Mhm.
regular, and that's kind of what I would focus on with this graph
Okay.
since we don't have the specific like objective measures for like total sleep time and stuff at the moment, but just kind of describing that visual trend. But
Mhm.
also, I think that in a meeting, Shan Shan did do some like initial analysis with this participant and did calculate like total sleep time, sleep efficiency.
Oh,
So let me reach out to her and see if that's easy for her to get. Like it's just the one participant. I feel like we could probably include that. And then you could, I mean, just for the one participant, have, your table side by side of sleep diary and actigraphy.
yeah. Sleep diary and make graph bigger. And then- Yeah. Okay. That sounds really good. So I will definitely address the stakeholder and like describing exactly who they are and doing a more detailed walkthrough so the sleep actigraphy data and making the graphs bigger.
Yeah, and then the other thing is I don't know exactly who your audience is gonna be. I did my PhD in farm talks, so like that audience, people are gonna ask questions about MOUD and want you to have like a really good understanding of that. And like the idea of like the rationale for why we're using a mu opioid agonist as a therapy for opioid use disorder. And then they're probably going to ask questions like, well, they're still taking a mu opioid agonist. Like, of course, they're going to have sleep problems. That's not surprising, or probably not going to be surprising to this audience. And so I would just have a good understanding of some of the literature that's coming out tying buprenorphine to sleep disruption. And then from there, you can also talk about, that's a reason why we really want to tailor CBT-I to people with opioid use disorder. And one of the key points that I would focus on is one of the things that we do in CBTIO is anchoring your like sleep prescription window to when you're taking your buprenorphine dose. And I think that I don't know how many farm talks people there are going to be in your audience, but I think that would probably resonate with people a lot as a concrete example of how we're tailoring CBT-I.
Okay, so yeah, emphasizing that connection with buprenorphine and sleep, and then also anchoring like this is why it's important, why we had to tailor our intervention to MOUD specifically.
Yeah.
Okay.
Oh, and Leah, to go off of what Madison just said,
Mm-hmm.
kind of she's a farm toxin pharmacist, so that's kind of like ingrained in my brain of what people would ask. But
Mm-hmm.
if you do have buprenorphine and methadone both within your slide, but then you switch and change to focusing purely on buprenorphine, which is fine, you may want to mention why, or like why not, and then like it depends on how in depth you want to go with that, but you can then pursue like buprenorphine versus methadone and the sleep, like the insomnia rates of the two. Why are you focusing on one versus the other? The prevalence of like, is buprenorphine used more than methadone? It is. Um, so like that's like you can take many different avenues from that, but whenever you just show two drugs of the same, and especially when you're talking about their mechanism of action being like partial mu agonist and a full mu agonist, someone may be like, oh, is that why? Is that the insomnia issue, like the full versus partial? So if you're gonna mention that, you might want to try to like cover at least a little bit of like the basis on just the differences between those two commonly used MOUD.
Okay, differences in terms of how it affects insomnia.
Yeah, you could. That's one path you can absolutely take. Yeah.
Okay.
Yeah, and I also, when you're talking about the options for MOUD, I would also include like naltrexone, naloxone, because
Oh yeah,
um,
Vivitrol.
Mhm.
yeah, those opioid antagonists.
Mhm.
And obviously that's not the focus of your talk, but that some people might have questions about that.
And I'm going to add on to this because I've given talks to these types of audiences myself, and I've been thrown off as like the clinical researcher, and we think differently, right, through science.
Yeah.
So in addition to everything that Austin and Madison just said, you also need to emphasize after you've gone through like these are the 3 FDA approved medications for OUD, and then this is buprenorphine is where I'm going to be focusing the rest, right? Because that is
Okay.
what, and the one of the, and then you can add your clinical research spin and be like, well, why are we focusing on buprenorphine? In addition to what Austin and Madison just said, the other reason why we're focused on buprenorphine is that buprenorphine is prescribed, it's given within an outpatient treatment setting. So you can say, I'm giving you clinical context to this medication, right? Because that's kind of the cool part that you have versus other people. Methadone is dispensed at a methadone clinic, but buprenorphine is given within the context of a visit where they see a provider who has the capacity in an outpatient visit to address comorbid clinical conditions like insomnia or depression, whatever else is going on. So that is the reason why we focused on buprenorphine actually for CBTIO, because it is feasible to address other things in the context of an outpatient clinic visit versus like standing in the line at a methadone clinic. You're not seeing a doctor or a nurse practitioner every day. The
Okay.
other thing that you definitely are going to have to focus on, and I've fallen into this trap before, is that the farm talks audience, for example, are going to say, well, if their insomnia is that bad, they should just stop the buprenorphine. But
Yes.
we all know that if a patient is gaining benefit from buprenorphine as a treatment for the opioid use disorder, we do not recommend stopping that medication because the overdose risk on a population level reduces by over 50% for patients on methadone or buprenorphine, correct? So we understand that, but the people, the people in a different perspective don't see that. So you also are going to say, also for clinical context, in these patients, we do not recommend that they stop the buprenorphine, even if their insomnia is terrible and it's, infecting their quality of life. So therefore, what's actually most patient-centered, which is what the patients told us in the qualitative interviews, is that they want to learn how to address their insomnia while continuing this buprenorphine, which is a very important medication for their opioid use disorder. And for a lot of patients, keeping them alive, right? Especially if they're continuing to use, et cetera. So that is an important point that people are gonna be like, oh, they should have just stopped the buprenorphine. No, 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 no. Continue it. And this is the point of addressing it with an adjuvant treatment.
Okay. That was very helpful because I didn't really think about these things.
Yeah.
Yeah, I definitely echo that. And like in the beginning, saying like just explaining like this is meant to be a maintenance medication and having some of those stats, like Dr. Martin said, like staying on this is decreasing their overdose risk. And like for clinical context, we're encouraging people to stay on this medication. Because a lot of people don't understand that. Um, yeah. And then another just like small comment that I had is when you show your graphs and start talking about sleep efficiency, I would just briefly go over like the formula for sleep efficiency and
Efficiency.
explaining what that
Yeah.
means. And so then when you have like your uh axis that's showing like up to 100%, people kind of have a context of like what that means.
Okay.
Um, and then I don't know about I um Dr. Martin's opinion on this, but I might even just go ahead and for your presentation, just clean up the sleep diary data. So if they like I know this participant had like some negative sleep times and like sleep
Yeah.
efficiency over 100%. I would just go ahead and clean it up so that you don't open yourself up to questions
Okay.
about that because it's not the focus of your talk.
I thought about doing that and then it got really late. And
Yeah.
okay. Well, I have a mom, so that's good.
Yeah,
Okay.
but I thought it was really good and you did a
That's
really great job of like explaining a really big project in like a really small amount of time and hitting all the main points. So really great job.
Thank you. Thank you for the feedback. I really appreciate the feedback. That was helpful.
Yeah.
And my dog also had to say yes too. Let me, and anything else? Should keep in mind.
Did you mention the like parameters for like what the sleep data could be or like the actigraphy data? So like they're
Like,
5 days, like 5 to 7 days, like we are ideally like because I don't know if anybody is going to try to count the blue line on those graphs, those little like
yeah,
I don't know if anybody's going to try to because like just because I know of like what it's going to show and like when we do
yeah.
quality checks we try to be like all right can we see like all the days or at least five like because I'm aware of that I'm just kind of more focusing on that. I don't know if other people will
Okay.
within the sleep community they might actually like that might be something that they always want to like look at. Not sure, but you may just want to like a little like half of a sentence kind of just saying like we were ideally or saying we wanted to try to ensure that we had at least 5 days of data with no more than two or with no less than or yeah no more than 2 hours of non-continuous wear blah, blah, blah. Yeah, so like
Thank
you just like provide a little bit of like your guidelines for what would qualify as this is good data to have. Like this is good. Like we've got a full thing to be able to accurately compare the before and the after.
Mhm. 5 days of data. Okay. And then you said 5 days of data without more than 2 days or
Without 2 hours of
2 hours?
2 hours of non-continuous wear. Or yeah.
Continuous non-wear.
Continue that one. Switch those
It's
again.
like
It's a Friday. I'm gonna go with that. Yeah, just non-wear. Yeah.
Okay.
They just basically we don't want them to not wear the watch for more than 2 hours because yeah.
Okay. This is QC. Okay. Okay. So in conjunction to everything else, it's just giving more details about the mechanism of the like all the FDA approved treatments and just emphasizing like the relationship with like sleep and buprenorphine. And then also just emphasizing like the sleep actigraphy data and also just including some stats about why buprenorphine works, why we don't want people to stop taking them. Okay. I gotcha.
yeah. And then sorry, this is a small thing. Slide 14, with your table, with the way it is right now for actigraphy, it looks like we're not getting the variables of sleep latency, wake after sleep onset, like, because it looks like it's different. Like we're not getting those from actigraphy, but we are getting those from actigraphy, and we're comparing.
I didn't know because like I wanted to like put like a I don't know what I got confused in how to set up this table.
Yeah.
You see how you have that you have the purple like color for variable name, sleep diary, actigraphy. Carry that purple color down the first column. So
This.
yep. So if you carry that like the white text, the bolded text, and then the purple color, then that kind of frames the table that the the side column, the first column and the first row are the heading rows in columns. And it's kind of like only reason why I know about that is because if you go in Word and then you like insert table, they give you styles, and almost all of them have the first one in the top row being the same color. And then that's just every time I've made a table for a paper, I've always just been like, oh, okay, Word does it.
And so like, do you mean like this?
So I don't know how you can tell the color, but what I would do is you see sleep latency that you're on.
Oh,
I would
change this color.
Yeah, the color that is in the variable name cell,
Yeah.
use that same color and change the cell box for sleep latency to the same color. And then awake
Okay.
after sleep onset, and then total sleep time, and then make sure that you have it the same font as variable name, sleep diary, actigraphy, and bolded as well, and white. So that way all of those are headers.
Okay. Let me just do, and then that'll give me a cue, and then let me change the color. Just right. Anything else?
No, awesome job, Leah. I'll follow up with you about I'll send the paper, development paper that Michelle wrote. And I'll ask Shan about getting these variables for the one participant that we're looking at.
Okay. And I may ask to review the beginning with you.
Yeah.
The beginning part about the y'all would be like the best people for that, farm talks.
Yes, I'm happy to.
Okay,
Yes.
perfect.
Happy to play devil's advocate and anticipate all the all the tricky
Yeah, greatly
questions that
appreciate
might
it.
come up.
Yep.
Yeah,
Yep.
I've never really given a presentation to basic science people before. So yeah, I'm kind of nervous for that.
It'll be
At,
fine.
mhm.
Yeah.
At a certain point, you know what you know, and then
Yeah,
you're the expert, and they're just here to listen to you.
that is true.
Hmm.
Yes, they don't know about how to do like clinical trials and what red cap is and like working with people and getting subjective data. So you're the expert in all of those things.
You're right. Okay. All right. Sounds good. Well, I'll look out for that stuff and then I'll shoot you an email. I guess I'll shoot you an email at some point before October 21st.
Okay, yeah, you have some time, right? So
Yeah.
that's the only reason why I was like, I can get those numbers from Shan Shan. 'Cause I wouldn't want to like throw it at you all of a sudden, but
Oh, yeah. No, it's October 21st. So yeah,
okay.
that sounds good. Okay. All right. Well, thank you, everybody. I really appreciate you all taking the time on your Friday to listen to me.
Great job, Leah.
Thank you. And you all have a nice weekend.
Yeah, have a nice weekend, everyone. We'll see you next month.
Bye.